I'm Peter Block, and TCT has come to an end. And this is the wrap-up we're going to do for the entire show here in Washington, D.C.
The whole
TCT,
shebang.
the whole shebang. So, Deepak, I think we have to identify what are the things that come out of here that are going to change the way we practice as interventionalists. So, Excel and Noble, two trials on left main stenting, quote-unquote opposite endpoints. I'm not so sure that's true. So go ahead and tell me your thoughts on this one.
Sure, so yeah, I think the top line message coming out of here is that Excel, PCI looks great for left main stenting, not inferior. The Noble trial, on the other hand, showing inferiority for stenting versus CABG for left main. So that's what the buzz is around here. But I actually think that's probably a bit of an oversimplification. I think the two trials are more or less concordant. You know, I think they both show, especially for early results, in lower risk patients, stenting is pretty good, almost as good as CABG, and a lot of patients, I think, would just say, if presented both options, as they should be by a heart team, yeah, I think I'll just go with the stent. I'm more worried about shorter term sort of outcomes. I'm not worried about what happens 3 to 5 years from now. Some others might say, I never want to come back to the lab, just fix me up, I'll have CABG. So I think they're pretty concordant that way.
Well, I think there's an interesting look at this. If you take the Noble outcomes, remember Noble's 5 years and Excel is 3. So if you take the Noble outcomes and go back 2 years to their 3-year outcomes, it looks just like Excel. And I interviewed the PI for Noble, and he pointed out very clearly that he thought this was probably new lesion problems that the stenting group, because you're dealing with focal lesions, just simply can't do as well with as coronary bypass surgery, and later you get more infarcts, and that is in fact what drove the difference.
Yeah, there's an excess in non-fatal infarcts with later follow-up in both trials, but mortality looked pretty good for stenting versus CABG in both trials. Right. What was a little bit surprising about Noble was they didn't count peri-procedural MI, so that is a difference between the two trials, and you know that could bias the trial towards CABG versus stenting, especially for early outcomes. The Excel trial showed an early hazard for CABG. That wasn't really seen in the Noble trial, which is a little funny. And stroke was higher in the PCI arm than the CABG arm in Noble, including later strokes, which doesn't totally make sense either.
Well, that may just be a play of chance. That's what everyone is saying. But you sort of scratch your head and say, why are we never using that unless we need it, right?
That's right.
And so I think one of the interesting things about these two studies is that both are randomized, both are done, as well as the folks that were involved could do them. And here we have different outcomes. Makes you scratch your head about randomized trials a little, and you wonder how much chance really plays a role.
It does, and we're kind of where we were before, except we've got more data. That is, I think you still need a heart team for many left main cases. If it's an osteo left main slam dunk, well, I would just stent it. I would have probably done that before. If it's a complex bifurcation lesion, high syntax score, there's a CTO on the right, well, probably that patient ought to have CABG, you know. So I think a heart team helps in the middle, but I think on the extremes it remains kind of clear.
I would agree, and I think the clue here is talk to your patients.
That's right. That is really the clue, because it does matter what the patient's preferences. You know, some are going to be really worried about the likely early hazard with CABG, and others will want a more definitive therapy.
Okay, so let's move on. We have not very much change for the left main stenting, perhaps, in the way we operate, but there is a big...
It might affect the guidelines, though.
Oh, no, I'm sure it will. In any case, what may change the way we do things? PFL closure, and I think that's really the major thing to come out of this meeting, which will change the way we think about stroke and taking care of it.
Yeah, I agree with you, and you know, I think in life as a clinician, as a trialist, you've got to be humble, and you know, I thought the trials to date were negative. It's not what I think. The primary pre-specified endpoints of all the trials were negative. There were positive signals, subgroup post-hoc analyses that looked pretty good, but now with longer-term follow-up from the RESPECT trial, you know, it does look like in the right patients, PFO closure does reduce the risk of recurrent stroke.
And this was intention to treat. This is not simply, you know, as treated groups. So
absolutely.
An important difference.
Yeah, so I think in the right patient, and that's generally speaking a younger patient with cryptogenic stroke, yeah, go ahead, close the PFO if they're at low procedural risk and if other causes of stroke have been ruled out.
One major caution, be sure you talk to your neurologist before you close it, because the carefully worded labeling on this device, and it is device specific, is make sure that there is a team approach with neurology and cardiology to evaluate the patient.
Oh, I think we've got to be honest, as an interventional community and a cardiology community, there were a lot of PFO closures going on for a while where the patient has a stroke, they have a PFO. If you're 80, 90 and have a stroke, it's probably not the PFO, and it would be hard to figure out if it is because there's so many other competing causes of stroke.
So there you have it, probably the thing that makes a difference in the way we practice. Yes. I think you need to be cautious, though. We can't just close every PFO that crosses the corridor. So,
absolutely. We can't repeat what went on a few years ago where there were really thousands of these PFO closures going on with kind of shaky indications.
Yeah. So something that really makes a difference, something that may make a difference and probably will make a difference in the guidelines. A fascinating 4 days here in Washington, D.C. at TCT.